Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this lecture of cholesterol biosynthesis and derivatives of cholesterol, I will be going over some of the applied clinical aspects related to this concept. Let's get into the details. Cholesterol gallstones. Whenever there is excess cholesterol in the gallbladder, because when a liver has excess cholesterol more than the need of the hepatocyte and also beyond the capacity of the hepatocyte to esterify that cholesterol into cholesterol ester and load it on to a ApoB100 molecule to make VLDL, so that this excess cholesterol is sent out into the circulation. One of the way to get rid of the excess cholesterol from the hepatocyte is to simply secrete that excess cholesterol into the biliary canaliculi so that it gets into the bile, and bile is momentarily stored in the gallbladder. Now what happens with that? So presence of excess cholesterol in the gallbladder, which goes beyond the capacity of the gallbladder to keep it solubilized, meaning that too much of cholesterol in the gallbladder, it can precipitate to make a cholesterol stones, and that is referred as cholelithiasis. There are two important factors that may lead to cholelithiasis. One is how often and how well the gallbladder is contracting, and also if there is any nidus which is available to initiate gallstone formation. Now some of the things that will increase the risk of cholesterol gallstone formation is the female gender, pregnancy, hormone replacement therapy, overweight, age at or above 40 years. These are all the risk factors for cholesterol gallstone formation. Directly or indirectly, in these risk factors there is a increase in the estrogen. So increased estrogen is one of the risk factor for cholesterol gallstone formation. Largely the stones present in the gallbladder, they remain asymptomatic. That means patients may not experience any specific signs and symptoms, although some of the non-specific signs and symptoms might be experienced by people having stones in the gallbladder. That can be feeling of abdominal fullness or distension of the abdomen, especially after eating a meal. Even a consumption of a small amount of meal may lead to abdominal fullness, feeling of satiety, like not feeling like eating, and also there can be flatulence. So this type of signs and symptoms, if it is seen in an overweight female who is around 40 years of age, a suspicion of gallbladder stone has to be arised. Presence of gallstones in the gallbladder may lead to inflammation of the gallbladder, which is referred as acute cholecystitis, and the acute cholecystitis may present with a referred pain to the right shoulder, severe pain which also accompanied by fever along with chills and rigors. And the secondary bacterial infection may associate with the cholecystitis, that is, can be because of E. coli or it can be anaerobic bacteroids. Some of the gallstones can escape gallbladder and they may be present in the common bile duct. And the presence of gallstones in the common bile duct is referred as choledocholithiasis, and this choledocholithiasis can partially block the common bile duct or it can completely obstruct common bile duct. So this type of obstruction may lead to lipid malabsorption because gallbladder content, which is bile acid and bile salt, bilirubin, cholesterol, all that which has to come into the duodenum, especially the bile acids and bile salts need to participate in emulsification for digestion and absorption of dietary lipids, and that doesn't go on. So this will lead to fat malabsorption, especially deficiency of essential fatty acids and vitamin A, D, E, K deficiency. Remember that. Coming to atherosclerosis and coronary heart disease. Atherosclerosis develops with increased plasma lipoproteins and the deposition of cholesterol and cholesterol esters into the arterial wall, especially in the subintimal space of the arterial wall. Now, any diseases that increases VLDL, IDL, chylomicron remnants, LDL, all these molecules, their metabolism, I have already explained in lipoprotein metabolism lecture. So, the increase in VLDL, IDL, chylomicron remnants and LDL can be seen in some of the disorders other than the inherited conditions. Here mentioned as diabetes mellitus, lipid nephrosis, hypothyroidism and other conditions of hyperlipidemia, including inherited causes of hyperlipoproteinemias. So these are often accompanied by premature or more severe atherosclerosis. There is an inverse relationship between HDL, especially HDL2, which is rich in cholesterol, ester and triacylglycerol. So the HDL2 concentration and the coronary artery disease, there is an inverse relationship. That means higher HDL and lower the incidence of coronary artery disease, because HDL is the one which will carry a cholesterol from the peripheral tissues to the liver. And this makes LDL to HDL cholesterol ratio as a good predictive parameter to detect coronary artery disease. Coming to regulation of serum cholesterol by diet. So simple reduction of saturated fatty acids and increase in monounsaturated and polyunsaturated fatty acids will improve cholesterol levels in the blood, because mono and polyunsaturated fatty acids have been seen to upregulate LDL receptors over the surface, thereby allowing LDL to be taken up from the circulation. And also it is important to keep a balance between omega-6 and omega-3 family of fatty acids, because omega-3 family of fatty acids eventually will be converted into eicosapentaenoic acids, docosahexaenoic acids. They will form anti-inflammatory cytoprotectant nature of molecules compared to omega-6 family, which will make arachidonic acid, and that will produce a pro-inflammatory type of molecules. So reducing sucrose and fructose in the food will bring down triacylglycerol and cholesterol levels, because excess sucrose and fructose is one of the risk factor for having excess VLDL synthesis and eventually having excess LDL formation. Now, omega-3 family of fatty acids believed to protect against cardiovascular diseases, because they will have anti-inflammatory effect and also they will have a lipid triacylglycerol lowering effect. And saturated fatty acids causes the formation of smaller VLDL particles that contains relatively higher levels of cholesterol, and that's the risk factor. That means consumption of saturated fatty acids positively correlate for development of coronary artery disease. Now the lifestyle changes need to be done, so that because lifestyle affects the serum cholesterol levels. Like additional factors that considered to play in the development of coronary artery disease includes high blood pressure, smoking, male gender, obesity, particularly the abdominal obesity, lack of exercise and drinking of soft water as opposed to the hard water. They all may lead to coronary artery disease contribution as the risk factors. Emotional stress and coffee drinking increases plasma free fatty acids and also elevated levels of very low density lipoprotein. Cardiovascular beneficial effects of estrogen in premenopausal women has been noted, because postmenopausal women will show almost same risk incidence than men for coronary artery disease. And also moderate consumption of alcohol may lead to increase in HDL concentration because of alcohol's effect on increase in the synthesis of ApoA1, which is the major apolipoprotein present in HDL molecule, and it is essential for the synthesis of HDL. And also alcohol, it modifies the activity of cholesterol ester transfer protein, and thereby moderate consumption of alcohol has shown a beneficial effect. And also particularly wine, red wine, because of its antioxidant content, may also prove to be beneficial. Now, importantly, regular exercise lowers the plasma LDL and also raises HDL levels, and regular exercise lowers triacylglycerol levels by increasing insulin sensitivity, thereby LPL activity can be increased. Overall, regular exercise will lower the lipid levels in a good way, that is going to lower the LDLs, lower triacylglycerol levels, improves the insulin sensitivity, and increases HDL cholesterol level, HDL molecules. So overall, it's a beneficial effect for us. Finally, some of the hypolipidemic drugs that can reduce serum cholesterol and triacylglycerol levels is like HMG-CoA reductase inhibitors, which belong to statin group of drugs. These are highly efficacious drugs in lowering plasma cholesterol and preventing heart disease. Statins, they act by inhibiting HMG-CoA reductase enzyme by competitive mechanism, and also statins have been shown to upregulate LDL receptor activity by decreasing LDL cholesterol inside the cell. One of the drug called 𝐒𝐧𝐼𝐻, this 𝐒𝐧𝐼𝐻, it is an inhibitor of NPC1L1, that is Niemann-Pick C1-like 1 protein, and by inhibiting NPC1L1 in the intestinal brush border epithelium, 𝐒𝐧𝐼𝐻, it decreases the absorption of cholesterol from the intestine. Other drugs that are used as a hypolipidemic drugs are fibrates such as clofibrate, gemfibrozil, nicotinic acid. All of them act mainly by lowering the plasma triacylglycerol by decreasing the secretion of triacylglycerol and cholesterol containing VLDL from the liver. Finally, we have PCSK9 inhibitors, that is alirocumab and evolocumab. These drugs, they are going to increase recycling of LDL receptors over the cell membrane and thereby decreasing LDLs in the circulation, and that potentially acting as anti-atherogenic. So this is all about applied clinical aspects related with cholesterol, biosynthesis and derivatives of cholesterol. I hope this video has helped you in understanding this very important concept. Thank you.